Welcome back to The Learning Curve. I am your host, Dr. Irtaza Asar, and today we're going to be re-examining one of the most sacred playbooks in medicine. For decades, ACLS has been our compass in cardiac arrest. It's been predictable, it's structured, it's algorithmic, but we're no longer practicing in the world where ACLS was born. We now have ultrasound that shows us real-time physiology, TEE that never loses the heart during compressions. We have arterial lines that tell us if we're actually perfusing. And we have eCPR that can pull patients back from the brink long after pulses disappear. Yet, in many resuscitations, we still default to the same steps that we learned 20 years ago. So today we're going to ask the uncomfortable question. Is ACLS saving us or limiting us? And what would a truly modern arrest algorithm look like? To explore that and returning to the podcast is the ever incredible prodigal son, Dr. Gavin Rogers. He is an emergency medicine physician, educator, and one of the leading voices in ultrasound education. He is core faculty and fellowship faculty at Riverside Regional, and he is the co-director of ultrasound education at EVMS at ODU. Today, he's going to help us step beyond the acronym. He's going to help us step beyond the algorithm and towards an approach where cardiac arrest isn't treated as a protocol, but as a dynamic, image-guided, perfusion-driven medical event. If you ever stood over a pulseless patient and thought, we can do better than this, you're in the right place. Gavin, thank you so much for joining me today, man. I really appreciate your time.
Thank you so much for having me back and for the ridiculously awesome intro there. That was fantastic. I'm just stoked.
I'm excited. It's going to be fun. I always think you got to get the WWE pyro in the background and stuff when you're doing these introductions. My technology hasn't caught up yet. So to set the stage for this conversation, man, let's talk about where you feel like ACLS hasn't caught up, right? So when you look at these current ACLS algorithms, where do you feel are the biggest gaps between the guidelines that we see today and the physiology that we're actually seeing at the bedside?
Yeah, I mean, I think that's a great place to start. In medicine, we have a lot of algorithms, and I think that's where ACLS falls into, right? It is a way for the lowest common denominator to practice medicine in a situation. If we think about ACLS, ATLS, surviving sepsis guidelines, right? All of these things where you have this patient, you do this thing, and you try and force a square peg through a round hole in a lot of cases. We do things based on the algorithm and we stop thinking. And I think that's where we fall short, is we stop using our clinical judgment and we stop looking at the patient in front of us and we just, what's the next step in our algorithm? When's the next 2-minute pulse check? When can I give epi again? What are my H's and T's? Did we think about them? And while that was great 20 years ago, we have so much more that we can offer the patients now.
And I think that's actually a great point, man. I also think about it in the timeline context of ACLS. So for folks that don't know, ACLS guidelines come from the American Heart Association. They typically release these guidelines every 5 years. And for the most part, in the last 20 to 30 years since we've had ACLS, that core algorithm hasn't really changed that much. There might have been some nuances here and there, but for the most part, they really haven't kept up with a lot of the newer technology, the newer pieces of information that we have at the bedside, things like echocardiogram, eCPR, dual sequence defibrillation. A lot of these other things haven't really made their way into that core algorithm. And my suspicion is I think the ACLS is probably going to get updated and maybe start to include some of these, but it's still not going to be to the extent that we should expect it to be. And I think your point still stands, right? This is a very broad set of recommendations to help even somebody that's just starting in medicine understand, hey, this is what I have to do in this situation. CPR, early shock is the most important. But then for people that define their identity as resuscitationists that have been doing this for quite a long period of time, we start to internally develop our own little nuances that we can apply to the patients where, hey, if I have refractory V-fib, I'm going to consider dual sequence defibrillation. I'm going to get the POCUS on early to make sure that I can assess for some of the things that might be potentially reversible and give me more information at the bedside. I think one of the best things that one of my previous mentors had mentioned to me is that if you're still doing ACLS 10 years out of residency training and you're just doing ACLS, odds are you haven't really evolved to be able to resuscitate the patient to the best of your ability. And I do suspect that ACLS is going to have some updates within the next 2 years because the International Liaison Committee on Resuscitation, what we call ILCOR, actually did recently release some new recommendations. And sometimes ACLS, the writers for that won't necessarily wait the full 5-year period, but we might get some potential updates. Any other thoughts on ACLS from your standpoint, currently where it's lacking?
So they just released, at the time of this recording, they released their updates for 2025. about a month ago. I was excited for some things. They did talk about using A-lines. They did kind of make the allowance for eCPR if you have the capacity to make it happen, if you're at a shop that has ECMO and can support it in the right cases. They talked about, I think, considering using ultrasound for your resuscitation. And I certainly understand where the group is coming from, right? They have to back up whatever they say with very strong, well, I should say they ought to back up what they say with very strong evidence. Probably something like a third of ACLS actually has really good evidence behind it. And then a lot of the other stuff is really just bad evidence and expert consensus. So I was a little disappointed that they didn't push a little harder for some of those things. But like you said, with ILCOR updating their recommendations, we may see some changes before the next 5-year mark, which would be great.
Absolutely. And I think hopefully those changes will help to refine ACLS so that we maybe apply it towards more unique situations as opposed to extend, like you said, trying to put that square through a circle peg and realizing, hey, it's not really working out. So from your standpoint, let's segue over to if we're trying to build a modern day resuscitation for these patients that come in cardiac arrest. Where do you think the role of ultrasound is in order to help us with these patients?
So in my mind, ultrasound should be on the patient as soon as possible. Now, I think you've got to manage a patient's airway. You've got to provide high quality CPR, and you don't want to interrupt either of those two things. But after that, you need to be getting the probe on the patient. And maybe I'm a little biased as the ultrasound person, but there's always evidence to back up my crazy statements when it comes to ultrasound. We talked a little bit about Gaspari et al.'s most recent publication in the Annals of Emergency Medicine from October 2025. At the time of this recording, hot off the presses, 6 weeks ago, they dropped this paper, and they found a 5.3% rate of occult V-fib in patients with out-of-hospital cardiac arrest. And this was a prospective study. It's probably the best data we have on this so far. And 5.3% of patients that had this occult V-fib had the V-fib on echo as opposed to on their bedside monitoring. So they've got their life pack on, they're doing the ACLS things, they put the probe on, somebody says the monitor shows asystole or pulseless electrical activity, and the ultrasound shows V-fib. And so the best part of that paper was those patients with occult V-fib, when treated as regular V-fib, had the same outcomes as patients with standard V-fib. So we are talking about orders of magnitude better outcomes for these patients if you identify the V-fib with echo and treat it as V-fib.
Absolutely. And I think that's really one of the pitfalls that I've noted as well with younger learners, where they're just focused on looking at the monitor, and you'll have situations where you'll detect fine V-fib on ultrasonography, and it's a huge number, right? 5%, that's nearly 1 in 20 patients that were potentially not able to appropriately resuscitate, give them that early shock that they need, try to get them out of this malignant arrhythmia. And that's huge, right? So let me offer a counter argument, right? Because sometimes what people will argue is that, well, if I try to use POCUS during cardiac arrest, I'm delaying that hands-on CPR time, right? Like, oh, the pulse check is going to get longer than 10 seconds, right? How do you make the argument against that?
There's kind of two ways that I talk about that. One, you should have the most experienced sonographer or ultrasonographer or ultrasound trained EM person or whoever. They should be the ones performing that ultrasound. This is not the time for the intern to learn how to do this. It needs to be whoever's going to be the fastest. When using transthoracic echo as opposed to transesophageal echo, which we can definitely talk about in a minute, when using transthoracic echo, I try and get the subxiphoid in these patients. It tends to be the least disruptive to compressions. It's one where I can have the probe on the abdomen during the last 10, 20 seconds of compressions and be ready to go and have my image very quickly. And then I think that we need to move away from interpreting that image in real time to saving a clip, right? Most of the machines have a 6-second clip save. In emergency medicine, I feel like a lot of us do a prospective clip, whereas the sonographers often do retrospective clips. But 6-second prospective clip, as soon as compressions stop, hit the button, find the heart, and then interpret that image during the next round of compressions. That way, you're not delaying CPR, which is one of the few high quality, evidence based things that we do in ACLS, and increase pulse check duration equals bad for patient. So we don't want to do that. There was an article recently that talked about a stepwise approach and an algorithmic ultrasound where they would do the ultrasound during the pulse check, and they would look for one thing, and then they would do the next round of compressions, and then they'd look for a different thing. And that is a great idea because it decreases your length of pulse check. But we have a video. And I'll be honest with you, I don't love delaying the pathology by 6 minutes because we want to do it in real time versus just let's review the clip. Let's take a minute and watch that clip again and again. Let's pause it. Let's slow it down. Let's do whatever we need to do to interpret it and figure out, hey, is there RV strain? Hey, is there a big pericardial effusion? Hey, is that fine V-fib? Hey, is that clot in transit? What do we see here? Is that valve messed up? Do we have massive valvular insufficiency? Do we have a pseudoaneurysm? Does the LV look just massive for some reason? Like maybe this person has known heart failure or new heart failure. There's so much that we can do with a 6-second subxiphoid clip that we shouldn't delay our CPR for. Real quick, back to that Gaspari et al., man. I looked at the cardiac arrest registry to enhance survival, the CARES, and it estimated about 350,000 cardiac arrests in 2024, and about 100,000 of those had ventricular fibrillation. If we look at Gaspari et al.'s findings, we would add 13,000 more patients to that list of people. Think about that number, 13,000 patients a year in the United States. Huge numbers that we are potentially not treating as ventricular fibrillation.
Absolutely, Matt. That's definitely a huge number. And going back to your point about, the pulse checks, and this is something that I try to impart on my learners as well, is that really you should not be taking more than 5 to 6 seconds to get that image. So if you're prepped beforehand, you can definitely mitigate the time that's needed to get that imaging because you're ready already, get that clip, and then during that next rhythm check is what we should be probably doing as opposed to a true pulse check. You can interpret those images and look for some of that pathology that you're mentioning, right? And from our standpoint, if we see that fine V-fib on the monitor, we can have the Zols ready to shock, especially when we need to, so that we can hopefully try to get them out of that malignant arrhythmia as fast as possible. And that's a pretty huge number, right? A lot of these patients potentially could be having this, and we're relying on a monitor which is not giving us all the information that we need. We're missing out on key pieces of information that potentially we can get return of spontaneous circulation a lot faster and then potentially have better neurological outcomes. Again, there's not a lot of data out there, but I think it is going to emerge in the next couple of years where I do suspect that this is going to make our way into these mainstream algorithms. So having talked about transthoracic echocardiogram and some of the pathology that we're looking at, let's talk about if your site has TEE. What benefits does that provide you in these cardiac arrest situations?
Yeah. I mean, TEE is the future. It is the future of resuscitation. My crystal ball doesn't work super well, but if I, pretend to look into it for a minute and say, what's going to happen the next 5 or 10 years? I think that TEE is going to percolate its way into CPR as machines continue to become higher quality and cheaper. The probes are getting more and more and more accessible, and we're seeing more and more and more research that demonstrates that, man, this makes us better. Like, this makes us better at resuscitation. Felipe Turan is one of the guys really leading the charge in this, and he's built the Resus TEE collaborative. And I mean, shout out to that guy. He's a rock star. He's fantastic. I love him. Every time I see him at a conference, I got to shake his hand and say, what's up? But he dropped a paper in February of this year, and it's from his multi-center registry. There's something like 28 hospitals in that system, and their numbers are crazy. So let me read you this quote from that paper. Pseudo-pulseless electrical activity was reported in 16% of out-of-hospital cardiac arrests and 27% of in-hospital cardiac arrests. Fine ventricular fibrillation was reported in 10% and 14%, respectively, as well as the initial area of maximal compression was determined to be over the left ventricle in only 28% of out-of-hospital cardiac arrest cases and 32% of in-hospital cardiac arrest cases. So that's 2 big pieces of information that we just got from his paper. And this is like 1,400 cases of TEE being used in resuscitation. So these are not small numbers, they're not huge numbers, but again, some of the best data that we have on this. And their numbers for fine V-fib were twice as high as what Gaspari was seeing. And that's huge. I don't know who's right. I don't know where that number is going to land, because Gaspari did a paper before his most recent one that was looking at prospective data that only saw about 3%. So we've got a range somewhere between 3 and 13%. I don't know exactly where it's going to fall, but it's probably somewhere between 5 and 10% if I had to take a guess. It's much more common than we think. So that's the first point. And the second point is we are not doing good CPR 2/3 of the time based on that information, right? We're compressing the wrong part of the body 2 out of 3 times that we are doing CPR. And what's the likelihood that you're going to get a patient back if you're not actually circulating the blood?
No, absolutely.
Probably rapidly approaches 0.
Because I mean, again, right? If for all the strengths and weaknesses of ACLS, one of the things that they do stress is that high quality CPR is the most important intervention that you can immediately intervene. But so if you're not doing high quality CPR, chances you're going to get return of spontaneous circulation back is fairly low. If you have access to that arterial line, if you have access to TE, you can get a definitive answer. Hey, we are doing high quality CPR, right? So it makes sense. Let's segue this conversation where you kind of hinted at this, right? TE is going to give us that continuous visualization during compressions, and that's a huge shift. So how does that change our decision making in real time from your standpoint?
I mean, in my mind, you get airway and you put in the TEE probe in these cardiac arrest patients simultaneously. That's going to be one of the first things that you should be taking care of as an ER physician. And you don't have to stop your compressions to put in that probe. You can throw in your airway just like you sometimes have to do during compressions, and you can put in the TEE probe during compressions, and then you get feedback. The cool thing about the TEE is as you drop the probe in, you get something called a mid-esophageal 4-chamber view. And it's like an apical 4-chamber view, just from the back end, from the esophagus, looking out towards the apex of the heart. And it is the prettiest view you ever will see because there's nothing in the way. It's esophagus, heart, done. There's no 400-pound morbidly obese individual. It's not a football player with a chest that's the size of my head. These are crisp, clean, beautiful views of the heart, and you get them really easily. You get that, and then you can watch compressions. You can evaluate for return of spontaneous circulation. You can look for the reversible causes, all the same things that we're doing with TTE. It's just better pictures. You're not interrupting CPR at all. In fact, you're providing real-time feedback on the quality of CPR. So you increase the quality of CPR, you improve your pulse checks, you can rule out stuff that you can't really see on TTE, like you can evaluate the aorta and say, oh man, this person's got an aortic dissection. And it's better. It really is.
Yeah.
Technically, institutionally more difficult, right? It can be very hard to say, I would like to buy a $40,000 probe that will require extra cleaning and maintenance, and I want to use it in people that are dead, right? That's really what you're doing. And it's the only ultrasound that has a kill count, if you think about it. I'm not going to kill somebody with my transthoracic echo, but if I perf somebody's esophagus doing a TEE, then it's a risk. But that being said, I watched The Princess Bride with my kids for the first time the other day. They're mostly dead at this point. The point I'm talking about, this intervention. So really, what is the risk stratification? What's a less invasive procedure for this person? A pine box to bedside? Like a shovel? At what point? All right. At what point do we say, well, that 0.01, 0.08, those are the ranges. That's the risk of a major complication with TEE, at least in some studies, right? That's a low risk. It's a low risk for someone who's dead. They're dead.
I 100% agree, Matt. I think about it in this context. With TE, you're going to get that superior image quality, right? You're going to get that continuous cardiac visualization. And there's observational studies out there that have shown that TE allows you to identify reversible causes of arrest at a much higher rate than other interventions that we're doing at the bedside for these patients in cardiac arrest. There's some observational data out there that in up to 97% of cases, it helps you detect things like fine V-fib, pulmonary embolism, cardiac tamponade, aortic dissections, intracardiac thrombosis. And again, these are all interventions that potentially we could intervene on to try to see if we can help our patients. One of the counter arguments that I've gotten from folks also is that, well, TE isn't really that feasible from an out-of-hospital standpoint. But again, there is still data out there where it is feasible in up to about 90% of cases where you can get excellent image quality during compressions, and you're not increasing the time that's off the chest while you're doing, standard CPR. And this has been compared to standard care, and they found that, hey, 90% of the time we can, even in those ambulances, we can get good, reasonable images that can potentially help guide our resuscitation and management. Let's look at it from a macro standpoint, right? We talked about transthoracic echocardiogram. We talked about TEE. So if, let's say, I'm at a facility and I want to take this to a tiered algorithm approach, where let's say I'm at a small community hospital or I'm at a rural hospital where I don't necessarily have the luxury of having eCPR, I don't have the luxury of TEE, what would my resuscitation approach be for a patient that comes in cardiac arrest? And let's say this is the most basic tier algorithm that we're going to talk about and apply for individuals that are at these sites. What would you say?
Right. And that is a super valid point. We run into these cases, or we have these discussions where it's like, well, I don't have TEE at my shop. I don't even have an ultrasound. I can't do ECMO. The nearest ECMO center is 2 hours away. And those are valid points because not everybody works at an academic medical center. So not everybody has access to some of this great technology. I think as far as the standard algorithm, you keep your CPR, you get your airway, you get your access, you do those things. If you have transthoracic echo, you get early imaging, during the pulse check, saving a 3 to 6 second clip, and view those images to look for reversible causes. If you have femoral A-line capability, that's your next step, right? So early imaging, look for reversible causes, look for fine V-fib, get an A-line. If you're solo covered, right, you're doing the airway, then you're doing the ultrasound, then you're doing an A-line. So you're doing a bunch of procedures really quick, but you just ask your nursing staff or your techs, like, hey, this algorithm. Tell me when the 2-minute mark is up. Give the epi when it's due. Don't ask me. I don't care. Just give the epi, and we'll figure the rest out while I get these other things done. We haven't talked too much about the A-lines, but I think a femoral A-line is going to provide real-time hemodynamic monitoring and also gives you some real-time feedback for your CPR quality. It's also super helpful if you're going to think about ECMO later. That femoral A-line can be upsized to do eCPR and ECMO. After you've got that stuff sorted out, you're going back, you're looking to see if the ultrasound has changed. So that's a dynamic process. The rhythm during the first check is not necessarily going to be the same as the rhythm during the third check. Sometimes you get the heart fibrillating and then it needs to be shocked. So you got to keep looking. If you have V-fib, I think you get 3 shocks and a dose of amio, and after that, you need to switch to dual sequence defibrillation. And again, this was not supported in the most recent guidelines. This is the one that I'm most disappointed in, is that dual sequence defibrillation or double sequence defibrillation was not recommended at all by the American College of Cardiology in their most recent ACLS updates. And that makes me sad, man. We don't have the best data, but we have a prospective randomized trial that showed unbelievable improvements in these patients. It is almost criminal to think that it wasn't at least recommended for consideration. Maybe not a strong recommendation, maybe hey, the evidence doesn't necessarily back it up, but we don't recommend dual sequence defibrillation has me heated. I'm mad about it.
Understandably so. And my hope is that in the next 5 years, I think we'll start to see that more mainstream in terms of resuscitations and management of refractory ventricular fibrillation. I'm also a big believer in it. I think the data behind it is starting to support it a lot more. It'll be interesting to see kind of where that lands in the next couple of years. But I do suspect that it'll make its way into the mainstream algorithms. I always think about it from the standpoint of why hasn't it? I think part of this might be just more so staffing versus equipment versus how do we get that second set of pads in there? But again, I don't think those are strong enough reasons to not actually potentially use it, right? Because again, when you're having return of spontaneous circulation rates that are much higher as compared to just regular defibrillation, it doesn't make sense not to actually even consider this, especially in those situations where you have somebody that's already been shocked 3 times, continues to remain in a ventricular dysarrhythmia that we have to essentially intervene on, and we need other options besides just what we've been doing for the last 3 cycles. So I think that's a great point. So we talked about basic tiers, right? So we talked about a facility that doesn't have TEE. We talked about a facility that doesn't have ECMO. So these are some things that they can potentially do to help manage the resuscitation of these patients better. So let's segue over to a facility that is more advanced tier. Let's say you're working at that academic site, or you're working at that site that has eCPR, that has TEE. What's your algorithm in that situation?
Yeah. So it also depends on how many bodies you have available to you. At my new site, we have a second year who is your proceduralist in the room with a third year who's running the code and the attending who's supervising. So we have 2 residents and an attending in every single code that we deal with. And that is, from a resource allocation standpoint, way different than when you're solo covering an ER, which I have also done, and you've got 2 sick people coming in at the same time and a cardiac arrest that you got to go deal with. It's a very different feeling than I'm going to focus on this one patient for the next 20 minutes. So definitely don't get me wrong. I have been in both situations, but same concept. You get your CPR, you get your airway access, you get your IV, IO, whatever access you're going to need for your medications, and you drop the TEE then. While you're doing the airway, you can insert your TEE probe, visualize it going into the right place, and then start that process so that you have your ultrasound guided CPR feedback and image rhythm checks ready to go. So get that going early. Then you don't have to worry about getting the clip and saving a clip. You just have constant, continuous ultrasound access. Somebody's doing that. Somebody else can be getting the femoral A line. The thing I will say about the femoral A line is you can't mess them both up, especially at a big academic institution, because that is your ECMO access. And if you poke a bunch of holes in the femoral artery because you've got one of your trainees learning how to do crash femoral A lines, if you do that on both sides, that patient can't get eCPR. They're done. They are removed from the eCPR algorithm at that point, which is dangerous. So you get somebody to get the femoral A line, and if they mess up on the first one, you have somebody senior do the second one, so as not to take away the capacity for eCPR. And there is a whole algorithm as far as people that would be good for eCPR. So the 80-year-old with known metastatic cancer who's still full code, probably not going to be an eCPR candidate. Okay to, potentially miss both of those femoral A lines. Not ideal, but potentially okay. Yep. The 30-year-old who had a witnessed cardiac arrest 5 minutes up the road from the hospital, who has been in V-fib the whole time, that is a person
Yep.
who may benefit from eCPR and who we need to be real careful with.
Absolutely. And I think that patient selection, I think, is very, very important, especially if you're considering that, because I think in those situations, you really want to make that decision and get your consultants on board early. And that's really where the EMS side of things, I think, really plays a strong role. So if you have a patient that you're overhearing, hey, we've got postpartum mother coming in cardiac arrest who's in V-fib, right? Already in the back of my mind, I'm thinking, okay, this might be somebody that I want to get my consultant down here while we're doing this resuscitation to see if we can potentially cannulate them, because that's really that prime candidate for ECMO, right? Versus, like you said, the 90-year-old individual who's got multiple comorbidities, they're most likely not going to be that candidate. So if I have somebody that I can be proactive about, get my consultants down early on, and then try to get that access, try to get all those things situated so that we can set these patients up for success, and also our consultants up for success, so that they're able to cannulate within a reasonable time frame, get them on the pumps, get them situated and stabilized at just a much better and faster rate. I think that patient selection, especially early on, is key. So in talking about that EMS mindset, right, how does that change in this new algorithm?
Yeah. So for probably a decade or so, EMS has had a stay and play mentality, right? And if you look at ACLS 20 years ago, where CPR, airway, epi, amiodarone, shock, if they're in ventricular fibrillation, lidocaine was in and then out, and then sometimes in again, those patients, there's nothing that EMS can't do. There's no benefit for them to bring that patient to the ER if they can do the same things that we can do. But that's not the case anymore,
Yep.
right? That has changed. And so I think the stay and play mentality has to change, right? In those cases, the best medication that EMS can give that patient is a heavy dose of diesel fuel. It's the foot on the gas. It's get them to the ER where
Yep.
we have better imaging modalities. We have 2 LifePaks to do dual sequence defibrillation. Some places have eCPR capability. We have A lines that we can place, and we can get real-time hemodynamic feedback. We can get real-time imaging feedback, and we can change the patient's outcomes. And so that's where things have to change, is scoop them, get them to us,
Yep.
right? Do what you can in the meantime, but get them to us.
Yep. And shifting from that stay and play to that grab and go mentality, I just think long term, I think that's a much better approach, especially with the interventions, like you said, that we have on the table now, right? Ultrasound, arterial lines, eCPR. If we can get that interprofessional coordination, especially early on, EMS to the ED, to cardiology, to ICU, to whatever specialist that you need to run some of these interventions, that's going to make it a lot smoother for our patients in the long run. You know ahead of time, hey, we've got that postpartum mother coming in cardiac arrest. I'm letting you know ahead of time. We've been in V-fib. We should be there in 5 minutes. Perfect. That gives me 5 minutes to try to get my resident situated. That gives me 5 minutes to try to get the arterial line equipment set up. That gives me 5 minutes to get my consultant down here so that we can potentially cannulate this patient and get him on ECMO as fast as possible, right? So that interprofessional coordination becomes so, so important.
In that last bit of our algorithm, right? If we have TEE and we've got it in, and we've got a femoral A line and it's ready to go, and it's that 30-year-old pregnant patient who's been in refractory V-fib, who no matter what we do, we can't get him out, or has a massive PE and we want to do eCPR, ECMO, whatever we can, right? Our ultrasound is ready. It's in the right place. Yep. We switch our view to what's called the bicaval view. We upsize that femoral line, and we watch those cannulas get placed in the right spot in the RA, and Bob's your uncle at that point, right? So this algorithm that I'm proposing is going to set us up for the best possible CPR and a transition to ECMO if we should make that decision.
Perfect. I love that. So to bring it home, you just brought up the algorithm. So what does a 21st century algorithm for you look like at this point in time?
I mean, in my mind, in the perfect world, this algorithm includes transesophageal echo. It includes arterial lines to monitor for both return of spontaneous circulation, a proper perfusing pressure, and to give some hemodynamic feedback to our CPR. It involves building of an eCPR program and ECMO. And if you don't have those things, it involves using an ultrasound to look for fine V-fib on the chest or on the subcostal region. An A line, if you do have them, for the same reasons, right? Hemodynamic feedback, fusing pressures, better pulse checks. These are not great for feeling a pulse. And there's so many papers. There's so much data that says your manual pulse check sucks. It does. It sucks. We should not be doing it. It is not good. So an A-line gives us that. And you don't have ECMO, you don't have TEE, it doesn't matter. You still have 2 good options, 2 good things that you should do that are at least supported by the ACLS algorithm. They're not recommended, but I think they should be. And then dual sequence defibrillation, right? If you've shocked somebody 3 times and you've given them amiodarone and they're still in V-fib, you need to do something else. You got to do something else. And dual sequence, we didn't talk about the numbers on those, but it's insane. 30%, right? So survival to hospital discharge in their double sequence defibrillation group in the big randomized study that was published in the New England Journal of Medicine, 30% of these patients in dual sequence defibrillation had survival to hospital discharge, and 27% total, 27.4, had good neurologic outcomes versus 11% who received standard therapy, right? So survival to good neurologic discharge, almost a 20% difference. And it's not recommended. It's not even supported. Come on, man. Come on. That's almost criminal. Like, I really think that we expose ourselves to some liability if we don't try it, because there's data that says, holy shit, this is good. It's like, this is really good. It's not just like a 1% difference. 20% difference is not something you can just like push under the rug.
Yeah, absolutely, man. Those are huge numbers, and now I'm already on board, man. I can tell why I was grinding your gears, but no, I
Mm.
think when I look at it from a macro standpoint, I think your point still stands, right? Is it almost has to be a mindset shift where we have to understand that these resuscitations, they have to start to become more individualized. They have to become more dynamic, and they have to be predicated on what physiology that we're seeing and what we're finding, right? So even if you don't have, let's say, TEE, you don't have eCPR, you still most likely have a bedside ultrasound, right? You can use that and integrate that into your resuscitation, get some dynamic physiology-based findings that could potentially give you a sense of what needs to be done, right? And I've gotten in the habit of, I've almost removed the word pulse check. I'm still sometimes somewhat guilty of it from my verbal dictionary. Now I refer to it as rhythm checks because I think that
I
tends to
love
be a
that.
more robust term so that everybody on board understands that, hey, we're looking for something that we can potentially salvage from a rhythm standpoint. I'm putting that ultrasound probe on. I'm trying to look for that fine V-fib because I'm not just relying on the monitor and I'm not just relying on my fingers to detect a pulse when I know the data says that I kind of suck at this, right? And that kind of makes sense. And obviously, there's going to be barriers towards this change. There's going to be folks that are saying, well, these are the guidelines. Yes, the guidelines are there for a reason. They're there for a foundation. You're going to build on those guidelines. You're going to add your experiences. You're going to add some nuances to this. You're going to add training and information is going to evolve. These guidelines change every 5 years. And if you're already 4 years from the time that the last guidelines were released, Azar, there's a lot of newer things that you could potentially be doing that could potentially help you manage these patients as well. So that would be my 2 cents. Now, Gavin, as time is running down, what are 3 key big takeaways that a first-time listener that's listening and tuning into this episode take away from this episode?
Right. So as far as 3 big takeaways, you should be using ultrasound in every one of your cardiac arrest patients. There is so much data coming out that shows that our standard therapy misses things. We just need ultrasound. And that's, again, I'm the ultrasound guy. I love ultrasound. Ultrasound is amazing. It's so cool. I love it. But I mean, really, the data backs me up here, from Gaspari's older paper looking something like 3 to 4%, to the newer papers showing 5.3%, to Turan's paper showing 10 to 12%, right? We are missing patients. It's somewhere between 1 in 20 and 1 in 10 that we can intervene on and have better outcomes on. So we got to use ultrasound. I think A-lines are an amazing tool that are very underutilized. At one point, I worked at a level 3 trauma center and we didn't have A-lines in the ER, which God, you want to talk about things that grind my gears? That's another huge one, right? I'm like, this is a trauma center. Why don't I have access to an arterial line here? So like I said, I've been at places where you don't have that tool, but if you do have that tool, you should use it. You should use it, right? You can see your pulse return. You can see a perfusing pressure. You can titrate your pressors if you get ROSC. It is a valuable tool that is way better than your fingers at feeling a pulse. And then I think the third one is dual sequence defibrillation. It is an absolute must in my mind in refractory V-fib. You should use it. And I think that you open yourself up to liability if you don't. 20% of your patients, 20% of your refractory V-fib patients coming back and having good neurologic outcomes is hard to argue with. So that's it, man. Ultrasound, A-line, dual sequence defibrillation. If I had to add a special fourth with an asterisk, it would be convince your EMS colleagues to get you the patients quickly so that you can use these interventions, and not at the 20-minute mark of the resuscitation, but more at the 5 or 10-minute mark.
Absolutely. I think those are fantastic key takeaways, man. I love that. And thank you so much, man, for sharing your incredible expertise on this. I think this is going to help some folks that are trying to rethink, okay, how can I be better at managing some of these patients that come in cardiac arrest? And what can I do something that's a little bit more different than what standard ACLS recommendations are? That's actually a really fantastic overview, and I really appreciate all the insight that you've offered. Is there any place on social media where folks can connect with you if they have any further questions about, let's say, ultrasonography or resuscitation during cardiac arrests?
Oh yeah, man. I talked about it last time, but I run a semi-anonymous, I guess not so much, especially after this episode, but a semi-anonymous Instagram page called ultrasound_nerd. just because I think we're all nerds in our own way, and
Yeah.
I specifically love ultrasound. So
Love that. The AHA is coming after you. Now they know.
yeah.
They're going to be dropping some comments on your next viral video. So I'm excited about that. So that brings us to the end of today's conversation. And if there's one message for us to carry forward, it's this, right? ACLS is a starting point. It's not the finish line. We have ultrasound, we have perfusion data, we have TEE, we have eCPR, and these aren't just extras anymore. They're how we move from an algorithm-based care to a physiology-based resuscitation. And the future of cardiac arrest shouldn't just be about following steps, but it should be about understanding what the heart is actually doing beneath them. A huge thank you to Dr. Gavin Rogers for sharing his insight, his passion, and his vision for a more modern, more informed ACLS, one built for the world that we practice in now, not the world that we created from guidelines from decades ago. If you learned something today, or if you're already trying to integrate this thinking into your own shop, I'd love to hear from you. Message us, share your takeaways, let us know how you are updating ACLS for the 21st century. And if you enjoyed this episode, please subscribe, leave a review, and share it with a colleague who runs codes. The conversations we start here only matter if they move back to the bedside. Until next time, stay learning.